am very, very pleased to welcome to campus this morning Mr. Tony Keck, who is joining us for our Breakfast with the Expert program. Tony relocated to our region about 1 year ago to join Mountain States Health Alliance as Senior Vice President and Chief Development Officer. Now, I'm sure some of us are wondering, what does a Chief Development Officer exactly do? And let me tell you, he does lots of things. So Tony is responsible for strategic planning, marketing, and communications for the whole system. That's all 13 hospitals, plus all of the other organizational entities that fall under the Mountain States umbrella. He is also responsible for the Mountain States Foundation and for government relations. In addition, he serves as the chair of the board of Integrated Solutions Health Network, and this is the umbrella organization that houses both Mountain States Accountable Care Organization and Health Plan. And in his spare time, he also serves on the Integration Council that is overseeing planning for the proposed merger between Mountain States Health Alliance and Wellmont Health System. Now, I don't know how he finds time to also guest speak and do events like this, but I'm certainly thrilled that he's interested in academia and in service and is able to be with us this morning. Tony joined Mountain States, as I mentioned, about a year ago, and he really brought with him over 25 years of healthcare management experience, public health leadership, policy development, and government service. Prior to coming to our area, he served for about 4 years as director of South Carolina's Department of Health and Human Services and as chief executive of the state's Medicaid program. This is a $7 billion Medicaid program, so this was no small project. And during his tenure, he not only brought back financial stability to the program, but he also implemented several initiatives to expand access to care to the vulnerable populations of South Carolina, while also improving birthing and other outcomes in the state. Tony has also served with the Louisiana Department of Health and Hospitals as Deputy Secretary, as Chief of Staff, and as Policy Advisor to the state governor. So he is certainly super qualified to be discussing how public health, healthcare, and payers can better work together. And for all of you students here in the MPH program, I would not miss this opportunity to say that Tony holds an MPH in health administration and policy. So with an MPH and lots of hard work, of course, you can go lots of places, and sky is the limit. So thank you, Tony, so much for being with us.
I appreciate that. You're the first person that got my job description right. I have a hard time explaining what I do, and it's been a while since I've been in hospitals, actually. I'm going to actually take a little bit of time to talk a little bit more about my career. How many people are first-year MPH students? Okay, and how many are PhD students or grad students? How many are undergrad? Okay, so sort of a mix of folks. I see a Michigan Wolverine back there. We'll talk about that in a little bit. But, so I'm going to talk a little bit about my career because I think it's instructive for folks who are in your position. I was down at Clemson last night. I was in Greenville for business, but my son goes to Clemson, so I stopped on by to see him. And I realized, he's at a point in his life where he's trying to figure out what his path is. And to me, it's so clear because I've already spent 30 years walking down that path, and I'm going to try on you what I sometimes fail to do with him, and sort of give you some guidance about maybe your career, because I think it's really important. Because we're going to talk a lot about policy today, just from my perspective. But policy without implementation is just somebody's good idea or somebody's opinion, and so it takes a career to really build up the experience set. So not only do you know what to do, I mean, lots of us know what to do. You can read about that in a book, but how to do it is a different story. So I'd like to start back in 5th grade, because I think that's actually when this all happened. Not very many people think about growing up to be a hospital administrator or running Medicaid, but I was in a talented art class, and I got kicked out of it in 5th grade because I skipped it so I could attend the other thing my class was doing. We had a substitute teacher that day, and I told her, I don't have to go to art class. I need to be here for Economy City. And Economy City was a business simulation where we were running a town, and I was a business owner, and my business was scooping ice cream and selling ice cream sundaes. And so I got kicked out of talented art, and I went to Economy City and sort of set my path to be a businessman for the rest of my career. But really, how I got in healthcare, I mean, it was an interesting thing, because I was an engineer at Michigan. And I was an industrial and operations engineering major, and the reason I had picked that major is because my father had identified at Georgia Tech, which was another school I was looking at. He said, hey, look at this really cool engineering program that's in healthcare. And this was 30 years ago, and engineers didn't work in healthcare. And it was all about improving quality and improving systems in healthcare. And I didn't end up going to Georgia Tech. I ended up going to Michigan. But while I was at Michigan, a few things happened. One, my mother got really sick, and she was in University of Michigan Hospital when I was in Ann Arbor quite a few times while I was down there, so I spent a lot of time in the hospital. I also met a professor who was the head of quality management at University of Michigan Hospital, which was a huge 800-bed hospital at the time. And he actually he was an industrial engineer, and so he taught a course in hospital management and engineering, and he became a mentor of mine. And then I volunteered at the hospital too. I was a candy striper. I actually had to wear like the little candy stripe outfit, and I would walk up to people when they got admitted, and they'd just been admitted for cancer or heart failure or something like this, and here comes little Tony Keck with my packet to tell them, this is what the hospital is all about, and you can call us if you have any problems. Totally clueless about sort of the experience that people were going through. But all those things eventually led to my first job in healthcare. I was actually bartending at a restaurant, and I showed up one day, and the doors were chained. That's how they close restaurants. They don't tell you they're going to close it because they're afraid everybody's going to steal the silverware. You just show up, and the doors are locked. So I had to come back early to get a job, and I walked into my apartment, and nobody had answer machines at the time. We didn't have cell phones, and the phone just happened to ring, and it was somebody from a healthcare consulting firm in town that I had actually applied for a job 3 months before, but a friend of mine got it because I didn't know how to use computers, and he didn't know how to use computers. And so he got there, and the last thing he was doing was using computers. He was actually tallying up thousands and thousands of sheets, like a check mark on a yellow pad with a calculator for some study they were doing, and he got so bored that he quit after 3 months, and so they needed someone to finish his project. So they called me up, and I happened to be standing in front of my phone because I came home early, and that's how my healthcare career actually began, as I started to work for that company while I was a junior in college, and we did surgical service business process consulting, and they had a relationship with my mentor, and he always would recommend people into there. So I got into that business, and a lot of it was number crunching, and I learned computers. That was back when computers were so slow that it would take 3 or 4 minutes just to sort something. But I learned, and I taught the organization a lot as a young kid. It was made up of doctors and nurses, but I learned an incredible amount. And actually, after school, started to work for them full time, and I got to travel around the United States because we did consulting projects. And so we were in lots of hospitals around the country. And as a young guy, I got to see lots and lots of different hospitals and meet lots and lots of different people. But eventually, two things happened. One, I got sick of my boss, or he got sick of me, or we got sick of each other, and so I started to look for another job. And actually, one day I told him I quit, and I didn't have another job. And he told me he was going to ruin my life if I didn't stay. That he would tell everybody who ever called Don Sullivan for a reference that Tony Keck was not reliable. So I ended up staying, and then 2 months later, I figured out the trick. If you're going to quit a job, make sure that you have a job lined up. And I actually got a job down in New Orleans, working for a large physicians clinic down there, doing management engineering, and eventually became head of the department. And then one day I was standing in the dry cleaners, and the chairman of medicine walked in. And the chairman of medicine at Ochsner was this like 6'4", big old white guy. And if you know anything about New Orleans, he was part of the old New Orleans family, old money, which had been around forever. And I didn't know him very well, and he walks up to me and says, "Is that your racism bumper sticker on the back?" We had these racism bumper stickers in New Orleans at the time, and I thought, oh, here it comes. I'm a liberal Michigan Yankee down in New Orleans, and I'm going to get a bunch of grief from the chairman of medicine now about what that bumper sticker is about. I said, yeah. He said, well, I actually run a clinic for the poor with my wife down in a neighborhood called St. Thomas Artist Channel. And he said, I'd like you to come on down and take a look at it because we just lost our administrator and I need some help getting it organized. And I said, oh, that'd be great. So here's the most unlikely guy in the world who, if I had never talked to, I would have had a completely different opinion of him, who's actually heavily involved in this clinic, for this free clinic, essentially. And so when I got down there, I thought it was so cool that I said, Don, I'd love to come down here and I'll run it for you full time. And so he thought that was great, and so I left my job at Ochsner, which was sort of a big corporate, and now it's huge. It's a several billion-dollar organization. Then it was really big, to go run this tiny little free clinic serving the underserved in New Orleans. And when you run a little business like that, you're responsible for everything. You've got to pay the bills, you've got to make payroll, you got to do the accounting, you got to do the scheduling, and it's a great way, and it was a terrific way for me to really learn how to actually run a business. And I like to say, if you haven't had to make a payroll in your life where people depend on you to get their paycheck, and a lot of the folks who worked for us were as poor as the people we were serving, you really haven't been in business. So it was a terrific experience. But then I was not making very much money, and I got married, and I needed to make some more money, and just out of the blue, the company that I used to work for up in Ann Arbor, that tiny little consulting firm, got bought by Johnson & Johnson, right? Big Johnson & Johnson with 100,000 employees. And J&J does everything from baby shampoo to Risperdal, antipsychotic medicine, to hip implants. And they wanted to get in the consulting business, so they called everybody up who had ever worked for them, and they asked them to come on back. And so my wife at the time and I just sort of picked up out of New Orleans and left and went back to Michigan. Well, I was essentially doing the same thing I had done before, and I was bored to tears. I was making lots more money, which was great for somebody who was newly married. But after about a year, I just said, I can't do this anymore. I'm going crazy. And so I tried to get another job and got offered another job to run a nonprofit consulting firm. But my boss at the time, who became really a lifelong mentor, said, no, just wait. We're going to find something really cool for you to do. And so I trusted him, even though everything was screaming inside me not to. And 6 months later, I got relocated to Santiago, Chile, to start up the Latin American consulting arm of Johnson & Johnson. And our target market was Chile and Puerto Rico, so I spent a lot of time flying between the two, and eventually we got into Brazil and Mexico and Venezuela and Colombia, and so it was a great experience that just sort of fell in my lap. I didn't know how to speak Spanish. All I knew is the job, the folks that I was working with down there, they didn't know the job. All they knew how to speak Spanish and English, and so they spent a lot of time, a lot of uncomfortable time translating for me in presentations like this, where I would talk for an hour and every 30 seconds I would stop, and then my counterpart would translate for me. And if you've ever sat through anything like that, you can imagine how uncomfortable it was. And I never really learned to speak Spanish that well. I could get around town and I could order and I could get on the plane, but it was clearly one of the most difficult things I ever did was jump into that new culture and have to adapt. And so I have a lot of sympathy for people who come to this country and have a difficult time speaking the language, because if you don't have your language, really for what we do, that's your single greatest asset, is being able to communicate to people your ideas. And if all of a sudden that's taken away from you, it's very difficult. And so I've always remembered that, and I think we should remember it today as we talk about a lot of the immigration issues that seem to be in the paper. Well, eventually I came back, and I'll sort of wrap this up, but I moved to New York. I spent a couple of years just sort of bumming around. I had convinced Johnson & Johnson when I wanted to leave after 5 years to lay me off, and since they laid me off, I got a big severance package, and so I could just sit around in New York and try to figure out what to do next. And so I started up a couple businesses with friends, which helped me pay the bills a little bit. But then I decided to go to Tulane, and when I went to Tulane, I got to teach, and I started to work on my doctorate. Got to do a lot of research, and then Katrina hit. And so I was in New Orleans in the middle of all that, and they canceled all the classes, and so for 4 months we were basically out of work and out of school. A lot of my work was actually outside of Louisiana, so I was one of the lucky folks who didn't have to, wasn't going without income for many months. Many folks did. But when I came back, New Orleans was starting to rebuild, and one of the people that I had actually done some work for the state as a graduate student was actually co-leading the process to rebuild New Orleans' healthcare infrastructure. Half of the hospitals got wiped out in New Orleans, half of the physician capacity got wiped out in New Orleans, and so everyone got together and said, well, if we're going to rebuild this, maybe we should rebuild it the right way, right? And so there's a lot of good effort of folks that came together, and I was sort of a loudmouth graduate student, and so I started to show up at these meetings with all these state officials and everything else, and I had plenty of ideas. And then one day, the woman I worked for asked me if I wanted to serve on a committee, and I served on a committee for quality improvement, and on that committee was my future wife. She was running that committee. I had been divorced after I got back from South Carolina, and about a year after that, we got married. Now, I tell you that story because we all became close friends, and when Governor Jindal got elected to be governor of Louisiana, my good friend became his healthcare transition leader. She came over to offer my wife the job of chief of staff and policy advisor to Governor Jindal. Well, my wife had just started a new effort, and I was sitting over on the couch typing my dissertation, trying to get it done. And for some reason, I just sort of leaned over and said, "Oh, I'll interview for that job," even though she had tried to offer it to my wife. And a week later, I was working as chief of staff to the CEO of Mountain States Health System, Alan Levine, and that's how Alan and I met. And so I never went back and finished my dissertation. It got very, very busy. The Affordable Care Act was being debated and eventually got passed. We had a lot of hurricanes that happened in Louisiana, and Alan really upended healthcare in Louisiana, so we had a lot going on, and so it fell to the wayside. But when Alan left to go work for a hospital company, he had been a CEO most of his life. He didn't recommend me to be the secretary in Louisiana. And you can imagine I was his closest advisor, and I had been busting my butt for the past 3 years, and essentially had assumed that I would be the secretary after that. And you can imagine the tough feelings that ensued during that time. But he told me, look, I would have recommended you if I thought that you were ready for the job, but I don't think you're ready for the job. You just need to be patient. And so he left, and I was stuck with a new secretary. I was the deputy secretary at the time, a guy who I didn't want to work for. So I started to think about moving on, and lo and behold, another day I got a phone call just sort of out of the blue. It was a guy who had been not hired, but was a friend of Governor Haley in South Carolina, who said, hey, we got a recommendation that you might be a good secretary to come on over to South Carolina. And the person who gave the recommendation was Alan Levine. So I went over to South Carolina, spent 4 years there. We'll talk a little bit about it. And then I pretty much promised Governor Haley I'd stay for her entire term. And then Alan got the job up here. And so at about the same time that Alan got this job, I was starting to wind down my 4th year with Governor Haley, and so he offered me the job, and here I am. And so I tell that big, long story because I think hopefully there's some threads you can see through that story. Is one, you got to always be open to lots of possibilities. Almost every, I always had a vision in my mind of what I wanted to do, and actually when I had graduated Michigan, I was going to go become a physics teacher. My mother had died, my girlfriend had left me, it was a big mess, and I said, I'm done with all this, I'm going to go teach physics. And I had applied to Michigan's graduate program and hadn't heard, and then at the end of July, I got the letter, and I must have been the last person that they admitted to that graduate program. And so I had to face this choice. All right, I sort of set this life path, and now all of a sudden I've got this opportunity. And I remember having a conversation with another person I worked with, and I said, look, I think with teaching high school, I think I have a certain opportunity of making a small difference in lots of people's lives. And I said, with healthcare, I have maybe a small opportunity to do something really big, like maybe be a health secretary one day. And I just was sort of dreaming back then about what I could do. But 20 years after just that conversation, I was health secretary and was able to do some really big things. So careers are funny, right? You got to pursue what you love. You got to pursue what feels right at the time. You can't be afraid to move sideways. You can't be afraid to actually take less salary if you want to do something different and learn. And I spent a lot of time just learning. I didn't spend a lot of time sort of moving up the corporate ladder. I bounced place to place, and I don't have a big pension. I don't have a lot of seniority, but what I do have is a lot of experiences that I really treasure. And I got a great wife with 2 kids and a lot of meaningful relationships. So your careers can be like that. Just be open and be ready to learn, and be ready to spend a lot of time volunteering, and always volunteer for jobs that nobody else wants. Get out in the field, and if you're going to work in administration, try to actually lay hands on patients. One of the things I did was took a second job when I was working at Oxnard as an administrator, working in an AIDS hospice, so I could actually know what it was like to have to work with individuals and all the uncertainty and terror that it involves to be on your own working with people who are very, very sick. But if you do that, you're going to end up with really meaningful, valuable careers. And so I probably took a little bit too long to talk about that. But like I said, I spent a lot of time talking to my son yesterday about what he was going to do, and I realized that we need more people. And if you all haven't identified mentors yet, you need to really think about finding a mentor, because they can really help guide you and help you maybe avoid some of the mistakes that we all make along our career. So any questions just about that really quickly before I jump into the main event? Okay.
Did you finish the dissertation?
I did not finish the dissertation. So I had got my prospectus approved, and really just had to finish, I guess, my 4th and 5th chapters. And, my advisor told me, he said, you're not going to come back, but he said, that's okay. He said, you're going to go do other things, and I don't think you'll ever make it back, but don't kill yourself over it. Don't kick yourself every year thinking, I haven't finished my dissertation. And so I for a long time in my bio, I listed, completing my dissertation at Tulane University. one day my wife was proofreading my bio for me, and she said, "Oh, I'm glad to see you change that." But she says it's a little strange. I said, "What?" It said, "Well," she said, you changed it to "you're contemplating your dissertation." So that's when I knew that it was probably time to take it off my bio, and so I guess about a year ago I did. And but you know, it was a great experience. I learned a lot. My classes were great. I used what I learned today. Taught a lot. That was a terrific experience. Got involved in a lot of research. So, you know, again, if you're open to sort of what's next for you, it all works out. Not to discourage any of you from completing dissertations and so on, because I think they truly are valuable, but I just had another path set for me at the time, a little bit by circumstances, but a lot by choice.
If you had to pick one event that was the game changer, which one would you put the timeline to that really pointed you in that direction?
Into sort of the work that I've done.
Yes, but you.
Oh man, that's really interesting. When I went to get my master's, an advisor who had advised my mother 20 years before said, "Why are you getting your master's? Just go to work on your PhD." And I thought about it over the weekend, and I realized that at that point in my life, 21, 22, that I wasn't interested enough in anything, one thing, to like devote my life to it. So I said, I'm not ready for that. But what I did do is I kept a list for the next 10, 12 years of dissertation topics. Whenever I got an idea of something that I didn't think worked right, I actually, and I still have it, I would write it down. Oh, here's a future dissertation topic. And eventually I got to like 15 or 20 ideas, and I said, you know, I think maybe now I'm ready. So I think probably being in Santiago and seeing a whole new culture, a whole new way of running health systems. I mean, every single country down there had a different way of operating their health system. We're going to talk a little bit about it today. Just sort of opened my eyes to what I wanted to do. There was obviously lots of poverty and inequity. In South America, I was living the life of an expat, and so I didn't have to deal with that very much, but I traveled a lot, and so I saw a lot of poverty, and you know, that sort of got my juices flowing. I always had volunteered in a lot of different sort of social justice type of things. I started I guess what now is considered New Orleans' most successful civil rights organization called the Fair Housing Action Center, which fights housing discrimination. After Katrina, we had to fight a lot of attempts to keep African Americans out of neighborhoods that they had traditionally lived in. A lot of that was at the policy level, a lot was at the legal level. So just being involved in that just opens your eyes. So, all right. So we're going to talk about the intersection of financing and health systems, providers, and public health. And so through my career, I've been involved in all of these. And the lines more and more blur, but I think there's some real distinctions between the three of those. And actually, when we take a look at those three systems, and they are three really separately functioning systems, is the financing of healthcare, the provision of healthcare, and then more of a public health approach. I think there's probably some learnings about why in the United States we're not getting the results that we want, and I'll argue that a lot of it is because those three systems are not working very, very well together. So when I think about this, I tend to think about, I try to simplify it so I can get up and make speeches like these without having to redo my slides every single time. But I try to simplify it in a few key statistics or facts or whatever, and a lot of what I do is go around and really explain to people who work, people in the legislature, because I have government affairs, and I did a lot of that down in South Carolina, Louisiana, but business people and so on, decision makers about, well, what's going on with our system and how can we do it better? So when I think about financing, which is how we pay for healthcare, one of the first things I think about is that, you know, in the United States right now, we're spending 17 to 18% of our GDP on healthcare services, and that's about 2 times the average for the developing nations. And our closest competitor, I think, is Norway, which is 11 or 12% of their GDP. That today is probably about $3 trillion. And I'm going to round these numbers. And so the other thing I think about from a provider perspective is that 1/3 of all healthcare spending is waste. And that's about $1 trillion. Anybody heard that number before, that 1/3 of all healthcare spending is waste? We'll talk about it a little bit, but this is pretty much an accepted number these days, is 1/3 of that. And then I sort of match that up and say, well, if you're going to spend all this money, we must be getting great results. But I think you guys clearly all know this, that, just on the most basic measures, we're 27th of 34 of the OECD developed countries in terms of life expectancy, right? And I could go over lots of other examples of where we're falling short. But when you put this all together, that we're spending the most money on healthcare, that 1/3 of it is actually waste, and that we are getting extremely poor outcomes, that's just crying out for some sort of solution. And so I've got a couple ideas about why that is. The other thing when I think about public health, and what's everybody's majors in here? What do you typically, epidemiology, maternal child health, community health, anything else? Administration, environment. Okay, so that's certainly. So you guys probably understand this, that, and this is the other frustrating thing, is that that when you think about really what drives health, what drives life expectancy, and lack of morbidity, it's really not healthcare services, right? The social determinants model. Have you guys all learned that yet? I'm sure with your dean back there, you probably had to take a test the first week you're here about social determinants. But 20% of health is determined by healthcare services. 80% of it is social determinants, and yet we're spending almost $1 out of $5 on healthcare services, and it's literally sucking the life out of every other thing that we do. And when I was health secretary, I was a member of a cabinet, and that cabinet was made up of, sort of depending on what state it was, you had your education secretary, you had your social services secretary, you had your economic development secretary, you had everybody who you had parks and recreation, parks and tourism, you had everybody who literally makes up a healthy community sitting around the table. And every year at budget time, when it would come around in my $7 billion budget, it was Tony Keck's budget that would suck every single available dollar that we had, and every new dollar that we'd have into healthcare. And so education suffered, and parks suffered, and economic development suffered, all because my system was this hungry beast, a lot of it by design, that continued to take more and more money to operate. And so we could invest less and less in education, higher education, early childhood education, school education. We could invest less and less in roads, which are key for economic development, and so on. And so I spent a lot of time as health secretary actually arguing, stop giving me so much money. And that actually generated a lot of controversy. And we'll talk about it in a little bit, but it generated controversy because, when you're in a legislature, you're the chair of the education committee, or you're the chair of the roads committee, or you're the chair of the healthcare committee. And when, how much money comes through your committee is a measure of your power. And so to have a secretary arguing, I don't want all this money, you should give more of it to education, you should give more of it to roads, you start to ruffle a lot of feathers. Now, I'll say one thing about this, because there's actually been a lot about it written lately. there's an idea that the United States actually spends less on social spending than the European countries, but that's really not accurate. We spend it differently, and so if you look at how much we spend minus how much we tax, and so you get sort of a net effective spending for social spending, we actually have the second highest level of social spending next to France in the world, or in the OECD countries. And so this idea that somehow the U.S. shirks a lot of its spending duties is actually not true. The problem is how we spend it, and there's two things that I'll argue create a lot of the problems that we actually see from the financing perspective. One is that we spend a lot of it on this, and so where we're spending all this money on healthcare, other countries that are only spending 10, 11, 12% of their GDP on healthcare, they're putting it into maternal leave, family leave for women and families. They're putting it into early childhood education for all kids that are, 3 and 4 years old. We're putting lots and lots of money into healthcare services, so we can't spend it on these other things. The other thing we do, is that a lot of our money is spent in the private system, okay? And so when you add up all the spending on healthcare and social spending, we look pretty good. But when you look at how other countries fund a lot of these services versus how we do it, we spend a lot of it in the private sector. Now, I'm a private sector guy who's worked for 2 very conservative Republican governors and been very active at the national level in Republican politics. And so to talk about spending in the private sector on social services being a problem is not a very welcome idea in Republican circles. But the reality is that when you look at the efficiency of this private spending, it's actually much less efficient than the other spending in the public sector that's happening in other countries. And if we have time, I could show you all sorts of interesting graphs about that. But the reality is that our private spending in the United States is very, very inefficient. It's also not very redistributed. And so we ask people to pay for a lot of this on their own, and they do. The problem is that folks who don't have very much can't pay very much, right? And so in other countries, when they take less of the spending burden off of individuals, they put it on the state is able to redistribute those dollars. And the reality is that when you're thinking about trying to improve public health, you've got to really think about all these folks over here, right? These long tails of folks that, or maybe it's over here, that are very, very, very expensive, that have multiple problems and are bouncing up against multiple systems. They might have mental illness. They might have heart disease or COPD. They might have food insecurity. They might be struggling with homelessness or temporary homelessness. But when you sit down and you start to add all that up, it's really a very small number of people who are costing you lots and lots of money. And then sort of, you've heard of the Pareto rule, the 80-20 rule, that 80% of the problem is caused by 20% of the reasons. In healthcare, and you can probably expand this to social services, we think about it like this. That this 5% up here, 5% of the folks in healthcare are costing you 50% of your spend. So 50% of that $3 trillion is being spent by 5% of the people. Now you can expand that into not just healthcare, but into, like I said, social services. And so if you're not working on a health disparities and an equity strategy, you're never going to improve health in the United States. And that's a pretty direct statement, and I'd like any of you or the faculty to challenge me on it, but I remember sitting in a meeting with Governor Jindal once, and he was meeting with the governor of Mississippi, and the governor, and so I don't know if you know much about Louisiana and Mississippi, but they share the Mississippi Delta right there, which is pretty much as poor a region as rural Appalachia. And Governor Musgrove told Governor Jindal, you know, he was trying to convince Governor Jindal we needed a Delta strategy. He said, if you carve out the Delta counties in Mississippi, Mississippi goes from 50th on the list, which they're 50th every single year in terms of health and social outcomes. They go to 24th on the list, right? And it's the same thing in Virginia. You look at Virginia. Virginia should be is one of the healthiest states in the country if you carve out Southwest Virginia. This is all wealthy, educated, and very healthy. This is incredibly sick and less educated and less wealthy, and it drags down all of Virginia. And so you can't think about state lines and state boundaries. You got to think about populations, and the populations that you have to think about are the populations that are extremely disadvantaged. This is where all the money is being spent. These are the folks who are staying healthy. These folks right here are the folks who are at high risk of popping up into here. And so when you think about a public health strategy, one of the things you really want to do is think about how do you keep these people from going up here. And so at risk can mean lots of different things depending on what population, what problem you're talking about. But this at-risk population could be children in single-family homes where the mom's not working, right? And that they haven't become this population yet. That's incredibly expensive, but there's a lot of indicators there that tell you that they could be, and so we need to pay attention to them. So that's sort of the grand view that I have of what's wrong in the health system. But I want to talk specifically about some problems that I think we can actually work on, that you can work on individually, or that you can work on from a policy perspective. And, you know, a lot of you might not be in a policy position for 5, 10, 15, 20 years. You never know, but these are 5, 10, 15, 20-year problems, right? And if we start working on them now, we'll get somewhere. The first problem from financing, from my perspective, having dealt with this as a state agency head for lots of different years, is the silos that we have in financing. And so if you, for instance, are worried about at-risk kids, and my wife and I have done a lot of work with at-risk kids. They're these kids that are not just this 5%, but are up here in the 1 to 2%, who are basically in every single system that we have in state government and local government. They're in juvenile justice. They've been kicked out of school. They have behavioral health problems. They've just got lots and lots of issues. And there's kids that cost the state $200,000, $300,000, $400,000 a year because of all their problems. And so when you think about trying to design a system to help those kids, you've got to worry about education. You've got to worry about mental health and addiction. You've got to worry about physical health, and so health services. You've got to worry about juvenile justice. You've got to worry about social services, such as child welfare, food stamps. You've got all these different systems that you've got to work about that have got to work together to actually figure out how to take better care of these kids. Now, some of these are run at the state level, some of these are run at the local level. So for instance, education, these are run at the local level. So most education policy happens school district by school district, county by county. Mental health in a lot of states is run at the state level. And so the state is making all those decisions. And in South Carolina, the state controlled all of the mental health services for poor children. In Louisiana, it was by region. Some places it's by county. But all of these are at different levels, and all of them have a different financing stream. So if you're talking about funding silos, you go from Health and Human Services, you have HRSA, which for those of you doing maternal and child health, that's where one of the main funding streams comes from. The Administration for Children and Families, which is child welfare and TANF and other services such as food stamps and cash assistance. You have CMS, which is health services. You have SAMHSA, which is mental health services. Then you have HUD, which is a whole separate cabinet agency. Then you have education, which is a whole separate cabinet agency. And all of those folks have their own rules, their own regulations, their own management structures, and they have all their own funding streams. And so all of these funding streams come down to the states and the local governments, and none of them have the same rules, none of them have the same target populations, none of them have even the same financing mechanisms. And so when these people at the local and state level are trying to put together a service for one kid, for one family, and we're trying to divide them up into 20 different little parts to say, well, you need to go over here to get this, and you need to go over here to get that, and I'm sorry, you're not eligible for this, but you are eligible for that. You can imagine the mess that we end up with. And so a lot of the work that we've done, and my wife does a lot of this work around the country, is what's called trying to braid these funding streams together, okay? And you have to get lots of special approvals from the federal government to do it, but it's hard. And the reason it's hard is why? Why do you think, I mean, and I'm just sitting here explaining this, and I'm assuming that it's intuitive, that when you got all these different funding streams, that, you know, it would make sense to maybe try to put them together to benefit the people that you're working for. Why do you think there's a lot of smart people up in the federal government, there's a lot of smart people at the state, why do you think it's so hard to solve this problem? Why do you think people like to keep these funding streams like they are? Why hasn't it changed if it's so straightforward that we should just try to get all the services for a kid who needs them when they need them? What's so difficult about that?
Job security.
Who said that?
I'd say part of it, you know, as I listen to this, I feel that part of it is just bureaucracy, just wanting to hold on to job security. This is the department that I'm in, this is my funding source, money's power.
Yeah.
That could be wrong, but that's just.
I don't know if I'm spelling this right, but my handwriting's so messy, most people can't tell anyways, but it's constituencies. Every one of these funding streams and every one of these departments is a constituency itself to somebody, to a committee at the federal level, to a secretary at the federal level, but they also have all their own constituencies, right, that they're trying to protect. And so you would think that the kids are the ones that we're most focused on and we should be centered on them, but in reality, you have a lot of cultural identities sort of wrapped up in this, right? I mean, this is why you have separate departments here, right? You've got epidemiology and you've got, well, here you've got epidemiology and biostatistics are one department, right? Is that correct?
Mm-hmm.
Well, in Tulane, there's separate departments. And I can tell you, if I went over to Tulane and said, you know what, why are you separate departments? That costs more. You could just have one department chair, and they do it over at ETSU. Can you imagine how hard they would push back on me? Because wait a minute, no, we're not biostatistics, we're epidemiology. Here it's the norm, but over there it's not. And so you have a lot of cultural identities built up in these organizations, but you also have a lot of financial incentives built up in these organizations. And it's power for the people who run these organizations.
Tony,
But
just one quick addition. It's not just bureaucracy, sometimes it's passion. Somebody believes, they're at SAMHSA, they believe that the most important thing in the world is substance abuse, and they want every dollar possible to go to bat. So it's partly entrenched bureaucracy, but partly it's that the participants' passion for what
Yeah, I agree, and so I don't want culture to be, when I say it's culture, it to be pejorative, because look, when someone comes up to me and sort of challenges my worldview, I push back, right? That's what we all do. And it's you've got to have a point of view to get things done in this world. But many times that point of view keeps you from getting done what really is best for the folks you work for. There's also a lot of people who depend on these funding streams who like it the way that it is, right? And so when you take a look at these organizations, really the smartest way to do this is to take all of this money, which doesn't get a lot of it doesn't get matched by the federal government, put it into Medicaid, get Medicaid match for it, and then that means that for every dollar you spend, the federal government gives you another dollar, for instance. Put it all in Medicaid and then redesign the services, and you can double your money by doing it in Medicaid. But the folks who have contracts with all of these individual organizations to provide these services, they don't like that because they're in a comfort zone. They have relationships. They have control over their contracts. They have their favorite contract advisor and so on. And so even the people who get the money, even though there's potential to get more money, many times push back on these things. So these silos are one of the single biggest problems, I think, that we have today. And there's a lot of push at the federal level in some quarters, and it's to some extent bipartisan, to try to collapse a lot of these, either through rule or regulation, or to actually rethink about how we organize these departments. So whether you're at the policy level or whether you're at the individual level and are in one of these departments and so on, and someone comes and sort of challenges your worldview, my plea to you is don't be afraid. Don't be afraid to change. Think about who your real constituency is. It's usually the folks, that are receiving your services. It's not the contractors you work with. It's not even the employees that are many times work for you. It's the people who are receiving the services, and you can't be afraid to do what you need to do for their benefit, and that's very hard sometimes. How much time do we have left? About 10 minutes. I'm going to leave a few minutes at the end for questions, but I'm going to jump past providers because we're doing everything perfect. And, I'll just say, actually, for providers, really quickly, this $1 trillion of waste, the Institute of Medicine has done some really nice analysis for us to sort of say where that is.
So
And
we have 15 actually.
Okay. They rank order it, and they say this $1 trillion of waste, or this 33% or 30% of waste, most of it's in unnecessary services that are delivered. The second highest category is administrative duplication. Then there's inefficiently delivered services. Then there's prices that are too high. There's fraud, and there's lots of fraud, but it's not the highest by far reason. And then misprevention opportunities. So we, like I said at the beginning of this, we know where the problems are, right? We know where it is. The problem is getting to it and trying to find it. And so why is it so hard to get rid of all this waste if we know where it is? That money's going somewhere, right?
The financial incentives are to keep it like this.
Yeah, and the phrase I like to use is one person's waste is another person's revenue, right? So I'll give you a good example for a provider. Hospitals have about 20% of their patients get readmitted. Okay, so you come into the hospital, and we do something for you. It can be give you a new hip, we do heart surgery, any number of things. And then within 30 days, you are back in the hospital. You're back readmitted to the hospital for the same condition. Okay, that's what's known as a readmit. Well, for a long time, when you would get readmitted to the hospital, which is a failure on our part to fix you, right? We tried to fix you, you left, and then you came back, so we failed. We would get paid again for that readmission, okay? That's how the system worked. So, notwithstanding the fact that most people who work in these systems want to do their best for the patient and are highly skilled, when you have lots and lots and lots and lots of things to worry about, the last thing you're going to worry about fixing is the problem that you actually get paid to fix, right? And so those readmits weren't the biggest problem because we got paid, and if someone was paying us for it, it must be okay. So we're not going to pay very much attention to it. But the reality is that it is a big problem. And so what the federal government took the lead on is starting to say, look, if you have too many readmits, we're going to start to penalize you. And then it's progressed where maybe we'll take 1 or 2% off the payment that we give you. But it's progressed to the point where they've started to say, we're not going to pay you for those readmits at all. Okay, now that was money that we were making that went to our bottom line every year. Now the federal government's saying, well, you can't do that anymore, so we're now extremely focused on preventing those readmissions. But that was real revenue to the bottom line of our organization. And so you can play that over 1,000 times in most organizations throughout the country that the waste in the system, in healthcare especially, is actually somebody else's revenue. And the way that the system is set up, where it was primarily a fee-for-service system, where we would get paid to do something. So every time you did something, you got paid for it. Instead of a value-based system where if you got a certain outcome, you would actually get paid. There's very few places in the world where you're not paying for an outcome, right? If you ordered fish at a restaurant and they brought you raw chicken, you wouldn't pay for it, right? Well, we tried. The guys were in the back. They were working, and I have to pay those guys, and I have to pay for the chicken and everything else. It's nonsensical, right? You wouldn't think of paying for that. But in healthcare, we do it all the time. We basically get paid for trying hard. We don't get paid for outcomes. And that's why we've had such a hard time getting to this waste, because people are especially protective of their revenue streams, whether or not it actually adds value to the patient. Now, in public health, I'll finish with this. I taught the same class over and over at Tulane, and it was a lot of it was the management course for the non-management students, and they did not want to be there. And it was a big class. It was like 80 people, and we were all packed in there, and it was depending on how the class was set up, it was an 1.5 to 3 hour class, and so it was not a great setup. So I used to have to think of ways to just sort of shock them out of their stupor. And the very first slide of my very first class started to be an example where it basically said public health students kill more Africans than malaria every year. And I'd get them all riled up about why. And my answer would be because of poor management. Okay? And that was what would set my class off. My class was about management, and so I wanted everybody to understand how important it was. I'll give you the example that I used to sort of make that statement, and I could give you many more, was malaria is fairly easily solved by mosquito netting, right? It decreases the number of people contracting malaria significantly. And so at some point, the Gates Foundation or the World Health Organization, I can't remember which, sent 3 million $3 mosquito nets to Uganda right, to be distributed throughout the country. And again, I mean, $3, a cheap intervention with good results. And about 5 years later, they went back to sort of evaluate the program, and the mosquito nets were still sitting in the warehouse where they had left them. And when the Ugandan Minister of Health was asked, why didn't you distribute the mosquito nets? His answer was, well, logistics are very difficult in Uganda. Okay, that was his answer. This is a world where you can get a Coke in every single village in the entire universe, regardless of how poor it is. And the health ministry in Uganda couldn't figure out how to get mosquito nets distributed throughout the country. My suggestion is give them to the Coke guys and let them distribute it out there. I have my same example from Louisiana. We had a swine flu outbreak, and this was a big deal because they were closing schools and everybody was terrified of swine flu in 2009. And we couldn't do the testing. We couldn't do the testing at the state lab, so we had to get the samples and we had to fly them out. And the governor was, of course, very impatient about when a case would be identified and trying to get the results back. And so we had a great epidemiology head, and he said, well, you know, it'll only take 2 days to get the results. We said, great, let's go, because this school wants to know if they need to close down, and you know, this is a big decision. And 2 days passed, and Alan went to Dr. Rickard and said, doctor, do you have my results for me? And he said, well, no, they're not back yet. And Alan said, well, wait a minute, you told me it takes 2 days to do the test. And he said, oh yeah, but we have a truck. And Alan said, what do you mean a truck? He said, well, we have a truck that goes around the state, and they pick up the specimens, and they have a route. And you know, Thursday wasn't their day to pick up the specimen, so it won't be 3 more days until we go pick up the specimen that we can send it out. Now, this was a town 45 minutes away from the capital, and so what did Alan do? He sent the state police to drive over there and pick up the specimens so we could send it out to the CDC. But again, logistics raises its ugly head where, well, you know, we've got a truck and it drives in a circle and we can't do anything different about it. So there are lots and lots of examples, and I ran public health in Louisiana for quite a few years. There are lots and lots of examples where good ideas and the right knowledge about what to do when that has been in place for years and years and years is stymied because we don't know how to manage. And management is not something that just happens. You're not just smart and you're not just personable. Management is something that you have to study. And you learn management by experience, but you also learn management by studying. And what I found, and my health degree is actually a master's of public health, not a master's of health administration, is that in my class and in the classes that I taught, is that there was really a severe lack of attention to the science of how do you get things done, implementation science. And that means understanding finance and accounting, that means understanding logistics, it means understanding organizational behavior and leadership development, it means understanding economics. And if you don't understand all those things, you are not going to be anywhere near as effective as you can be, because not only if you're ineffective are you not always going to get the results you want, but you're also going to be wasting lots of money that could be spent somewhere else on somebody who needs it or trying to reach more people. And so if I had one thing to say to my public health brethren, and I do consider myself a public health person, and sometimes to the chagrin of all the hospital people that I work with, but you've got to focus on good management. You've got to understand how to take all your passion and all your good ideas and figure out how to actually make things work, how to inspire people, how to organize, how to pay for it, because otherwise you'll never get everything done that you want to get done. So with that, I'll open it up to more questions. Sorry, I had to rush on through that last little bit.
So Tony, I'll start with the question. One of the realities of the world we live in is that there are elected officials on both the right and the left who have very strongly held opinions that don't always match the facts. What approaches have you found that were helpful for you at the higher levels of being able to deal with folks on either side of the spectrum?
Well, that's a good question because I'll just tell everybody here. So I voted Democrat up until President Obama's second term, and so I've been a lifelong Democrat, working on social justice issues. But I went to work for an incredibly conservative governor in Louisiana and an equally conservative governor in South Carolina. I made that choice for two reasons. One is because I believe they were people who were most interested in getting things done. And in most cases, they turned out to be people who asked, what's the right thing to do first, and then the politics question was second. Never be mad at a politician for thinking about politics, right? We get all worked up. Oh, they're so political. Yes, they're politicians. But if they put it in that order, what's the right thing to do, and then what are the politics? They usually end up in the right place. But what I did is, I talked about having a clear point of view. You have to have a clear point of view, and you have to sell. And when you have a clear point of view and you're researched, and you know how to sell, I typically found for most of these issues, it's just about how you talk and how you present it to folks on different sides. And so one good example was enrollment in South Carolina. When I came to South Carolina, there were 500,000 men, women, and children, mostly women and children, who were eligible for Medicaid but were not enrolled in the program. The dirty secret about Medicaid throughout the country is that states would make it difficult for people to get enrolled so they wouldn't have to spend the money, right? I mean, that's how they managed a lot of their costs. And so when I went to South Carolina through my confirmation hearing, a Democrat senator said, "Are you going to do a better job of getting everybody enrolled?" And I said, "Senator, you decide who is eligible to get enrolled. My job is to implement that decision, and I will get everybody enrolled." Now, there were lots of sort of Republican pundits who screamed that I was expanding Medicaid through the back door, and I was opposed to Medicaid expansion, and I still have a lot of reservations about it. But what my argument was to conservative legislature were a couple things. One is that, look, my point of view is that governing conservatively means making a few promises, but then keeping those promises. And if you're going to make a promise and you don't keep it, that's not conservative governing, and that's what we're doing right now. We've made a promise to folks, we've made a policy decision, and we're not keeping it over here. The other that was sort of a policy-based sort of or prescription. The other more political approach to it was, I said, look, if you're going to have to fight expansion for the next 4 years, and one way to do that is by showing people how expensive this program really is by getting everybody into the system who deserves to be in it. And when I was at Medicaid, we grew the program from $5.2 billion to $7 billion in 4 years. We didn't do that by accident, we did it by choice. Now, was that my real reason for expanding it to all those kids? No, my real reason was because we had made a promise, and two, kids are a good investment. And we needed to have all those kids in the system. But how you explain it to different constituencies, it's not being dishonest, it's not being disingenuous. It's talking to people about what they care about and presenting them the facts in a way that they can understand. And so, in South Carolina, we moved up 7 rankings in the Kids Count health rankings in 1 year because of the efforts that we had around increase in enrollment. So you can really move the needle quite a bit. And we had Republican and Democrat. Like I said, there's a lot of people in the blogosphere that complain, but you can't read that stuff. You drive yourself crazy. Any other questions? I know you guys got class.
You just mentioned briefly that you have some reservations about the concept of expanding Medicaid. So is it just the expense, or are there other reasons why you don't think that would be a good idea?
So I've never understood what I understood, but it doesn't make sense to me that the most expensive healthcare system in the world, that the way to solve the problem is by putting $1 trillion extra in it over the next 10 years. And I understand why President Obama did it. He had both chambers of Congress, and Democrats tend to want to grow programs, and Republicans tend to want to shrink them. And so he said, I got 2 folks, let's grow the program. Now, if he had done what I would advocate for, and actually what we did in South Carolina, which is to dig into this and redistribute the money, I think there is enough money in the system, the 17 to 18%, there is enough money in the system to get everybody the health care they need. If he had done that, if he said, well, you know what, we're gonna take the money we have and we're gonna take a whole bunch of it from the hospitals and we're gonna put some of it over here. If he had done that, he would have had both chambers of Congress and both parties up in arms, because the hospital lobby and the pharmaceutical lobby and every other lobby gives equally to Republicans and Democrats. And if he had said, we're gonna pull all this money out and we're gonna redistribute, and to some extent they did do that a little bit, he would have had a fight on his hands he couldn't win. So I understand politically why he took the more inefficient policy route to get more people covered. What I argued is that we needed to take a different approach at the state level, and it goes back to what I had talked about in terms of social determinants. South Carolina wasn't Massachusetts, right? Massachusetts is one of the wealthiest, one of the most educated states in the country. What they made was doctors and PhDs. South Carolina was one of the least educated, least wealthy states in the country, and what we made is peaches and BMWs and Boeings. We were on a completely different part of the economic continuum. And there's a good argument, and actually there was a big case going through the Supreme Court in South Carolina, that what South Carolina didn't need to be spending its extra money on at the time was expanded health care, but what it needed to be spending its extra money on was fixing the inequities between rural and non-rural school districts, which was going to cost hundreds of millions of dollars a year. And so, every state is different. One thing that I appreciate about Governor Haley, she never criticized other states for expanding Medicaid. She never said Medicaid is wrong, expansion is wrong no matter what. It's just not right for every state at every time. And so what I said is, look, let's get the program in shape. Let's get all those kids who aren't enrolled into the program. Let's get all those people living with disabilities that are on waiting lists, off those waiting lists, get that all taken care of. And then when we see sort of how much it costs, and we've invested money in some of these other areas, then let's talk about how to restructure so we can get everybody into the pool. So that was mine. Now, I had lots of good arguments with folks about whether that was the right way to do it. It does have implications of equity, and there were people that were left behind for a certain amount of time, but when you get into a policy-making world, every choice you make is leaving somebody behind. You are never not hurting somebody. And what you have to do is you have to weigh those decisions. So I see people getting up and going to class.
Folks, I hate to interrupt this wonderful discussion. Actually, Tony and I had talked. He's happy to visit with you in the student lounge for a few moments if anyone has additional questions or comments. But we do need to wrap, this part of the program up to allow the class to come in. I do hope, and I know that you enjoyed this as much as I did. So let's please show Tony how much we appreciate it.